Tudo bem, então, boa noite, pessoal. Muito obrigado pela presença de todos que estão aqui conosco hoje. Sou Hugo Farias, do marketing da Rastreal. Estamos aí dando início nesse webinar que vai falar sobre ondas cerebrais, como ela pode ajudar no foco, no humor, no sono e também no aprendizado. Este é um webinar que estamos desenvolvendo aí junto com a iMedSync, com também Dr. Bruno Pessoa, e a Universidade Federal Fluminense, junto com o UAP. Bom, para começar, somos a Rastreal, somos os distribuidores master da solução eMedSync no Brasil. Temos aí uma grande experiência em implementação e desenvolvimento de tecnologias médicas complexas no setor de saúde no Brasil. Aqui hoje contamos com o pessoal da eMedSync. Muito bem-vinda, Nicole. Obrigado, Carlos, também pela presença. Esse aqui é o time completo da eMedSync, que alguns não puderam estar aqui hoje. A iMedSync é uma ferramenta guiada por AI que utiliza EEG para cruzar informações e a gente tem aí algumas áreas de utilização na saúde mental, pediatria, autismo, esportes, prescrições médicas, neurologia e várias outras especialidades. Doutor Bruno, você quer seguir com o restante? O Doutor Bruno agora vai apresentar o Dr. Bryan Butler. Obrigado, Dr. Bryan, pela presença hoje. Vai estar aqui conosco, compartilhando a experiência dele aí na utilização da tecnologia nos Estados Unidos.
Obrigado, Hugo. Obrigado a todos que estão aqui presentes, né, para esse webinar, que para mim é o primeiro webinar desse modelo e que o jogo começaremos com o pé direito, né? Eu vou apresentar alguns dados aqui do Brian, que é um colega que eu tive a feliz oportunidade de conhecer no nosso encontro lá com o Jay Gookman na Califórnia. Então, primeiramente, o Brian é um colega que é psicólogo, né? Ele tem graduação em arte, teologia e psicologia e tem trabalhado desde então com diversas ferramentas que dizem respeito à questão da saúde mental, né? E ele já é licenciado e é um profissional bem experiente no Texas. Ele é Board Certified em Neurofeedback desde 2023, mas já tem o BCI, que é o título que o autoriza a fazer isso, né? Trabalhar com essa ferramenta desde 2016 e com uma formação extensa em eletroencefalograma e QEG, que é a ferramenta que permite que o profissional que trabalha com QEG, fotobiomodulação, possa fazê-lo, o certifica, né, para que ele possa analisar os dados do QEG e assim implementar as terapias, quer sejam de fotobiomodulação ou então neurofeedback, e tem trabalhado há bastante tempo com isso. A gente está, aqui seria um material de apoio, que eu encorajo vocês todos a fazerem o download, que é bem interessante o material que o Brian compartilhou conosco. E isso faz parte de um projeto que nós começamos lá atrás, junto com a eMedSync, com a Rastreal aqui no Brasil, que é a empresa que importou a solução eMedSync para o Brasil, através do Marcelo e todo o time. E é com muita alegria que a gente vai ter esse webinar hoje, que tem um foco não somente nos nossos alunos, estudantes, para divulgar a função do QEG como uma ferramenta que pode ser muito útil no meio médico, mas também com o objetivo de pesquisa clínica e pesquisa em neurociência, que é ao que nós nos dedicamos na universidade também. Então, a gente tem utilizado essa ferramenta, que é a ferramenta da eMedSync, né, conforme eu falei, com um apoio muito grande da Rastreal, e a gente sabe como, em termos de América Latina, você viabilizar uma tecnologia dessa não é fácil, e o apoio da Rastreal tem sido absolutamente fantástico para proporcionar isso, não só para os pacientes, mas para a gente, nós médicos e para os alunos. E hoje o Brian vai falar um pouquinho da experiência dele, do uso do QEG que diz respeito principalmente ao foco, né, atenção, o humor, sono e também aprendizado. Então vou passar a palavra agora para o Brian.
Hello. Hi. Sorry, I'm watching Bruno and then I'm hearing Monica speak. So there's a little bit of delay. Like, okay, he's talking to me. Hi. Um, I'm Bryan Butler. I'm not a doctor. not a psychologist, but I am a licensed professional counselor. I just want to say thank you to Dr. Bruno for asking me to come speak with you all today. I met him at a conference in San Francisco, Jake Uckelman's conference, and I was just impressed with his professionalism, and his passion to find different modalities, treatment modalities to help improve his patients' quality of life, and his passion in doing so. So, and that's why we're here today, is about quality of life. So, I'm a kind of a unique individual, and trying to keep this in mind to speak a little slower. So I may read something, because if I read them, it'll help me go slower. So, um, but what I really want to do today is help you understand the merging of the world of neuroscience. So we call this, the field that I do is really more of a functional neuroanatomy. Uh, so we're basically, I'm a therapist and a licensed professional counselor, but I also am board certified in neurofeedback. And the reason why I do this is because I'm going to share with you some of the concepts of EEG and neurotherapy within my story. So, I spent most of my life, I grew up in a lot of abuse. And so kind of my life has been a journey to find the best tools to get better. And so when I got much better, then I started doing the same thing with my clients. That's what I do today. So I kind of started late in life. Was it Jung says that life doesn't begin until 40, and everything before that is training, something like that. So it wasn't until the age 45 that I found brain training. So it changed my life, and so I've been doing that ever since. And so I'm going to share with you some of these concepts, but then the context of my story. Am I speaking too fast? Is that okay?
That's great, Brian. Can't stand everything. Keep going, please.
Okay. So, by the way, has everybody downloaded the two things? There's a B-Man's chart, and the other one is a combined head map of functions, and that's going to give you some resources to better help you understand how we do what we do. And then, like told Dr. Bruno, if he asks me a difficult question, he knows more about the brain than me. So, um, so if he puts me on the spot, I'll just turn it back on him. So. All right. So, since everyone has that, let's just start with just the foundation of EEG, brainwaves and neurofunction. So, what EEG measures, it's electrical activity from cortical pyramidal neurons. I think most of it comes from the 6 centimeter sort of space between the neurons. Summated scalp potentials, larger amplitudes reflect greater neural synchronization. EG offers superior temporal resolution compared to fMRI or PET, while QEG adds quantitative analysis. What that means? Go ahead.
Brian, I'm
Yeah.
sorry. Yeah, we can see your screen. At least I can see. I can see your screen.
Yeah,
You
you're
guys
not
can see
sharing.
it?
You're
What?
not sharing it.
Yeah, you're not sharing it. Exactly. Your screen.
Oh, oh, oh. Oh, so I'm running it. Okay.
Yeah, exactly.
Oh, hold on. I
Yeah.
got it. Just a second. Thank you.
No problem.
Yeah.
That happens. It
Stop
happens to
looking
me
at me.
all the time.
All right. Okay. I'm a little nervous. Here we go.
We're a little family, so don't be nervous.
Yeah, exactly.
It's all cool.
Yeah.
Yeah.
Now we can see.
Yeah.
Yep.
Okay. Let me
I
just
think
make
you
it
can
let
just
me make this
maximize the screen, maybe. Yeah.
start slideshow here. Yeah. There we
There you
go.
go. Yep. Nice.
That's perfect.
Okay.
Mhm.
So let me share a few things. So when I have a new client, so I'm going to do EEGs. So I do an EEG, 19 channel 10-minute 19 channel eyes open and a 10-minute 19 channel eyes closed. And so I'm looking at the raw EEG. Look at the background noise. Three of the things that I look at when we're looking at EEGs is the brain state and background normal. So for instance, if somebody has their eyes open and within just a few seconds or a minute or so, they start to create these frequencies like they're about to fall asleep, that tells me something about their state change. Um, so, and then we look at, are there abnormalities and how is the brain organized? So like things, medical abnormalities or functional network dysregulation. Um, you can see those in this. I don't know if you know or ever heard of this, but there's a triphasic wave. It's pretty cool. So when you see something like that, it's usually a metabolic issue. It could be thyroid, could be the gut, could be liver, could be things like that. And so that's when I see something like that, it tells me that I need to send clients to a functional medicine doctor. And every time I do, there's always some sort of metabolic issue that's causing problems. So that's a pretty cool thing that you can find. Um, the morphology has to do with things like, and I'll show one of my cases, a lambdoid. So lambda is an EEG frequency that when you're looking for danger in your visual field, you see that. But when your eyes closed, if you see that morphology, it's a marker for trauma. And and during all this stuff, that's kind of the things with the EEG. You can find everything. I'm just fascinated with it. But there is some theoretical framework used because there's not often a slam dunk. But if that makes sense. So you're always looking for little clues. So maybe trauma doesn't look the same way it would for this individual, but when I see a marker like that, their eyes are closed and they've got that lambdoid. It just tells me their eyes are closed, but they're still looking for danger when their visual field is closed, so they shouldn't be. So it's a sign for hypervigilance. Um, and then we look like underlying issues as well. Like if there can be spikes or transient waves where possibly they're not getting enough oxygen, but it also is kind of, and typically neurologists don't look for this. They're typically for seizures that are very obvious, but transient and these spike waves, you can find them and they're kind of precursors to seizures. And so if you can train them and calm them down, and I've done that before. I've had somebody had a stroke, and then we just began to train that transient that kind of was just sort of a precursor, just kind of waiting to happen. And we just kept training that, and then she was able to stay stable and not have another uh, stroke. Um, and then basically looking at what do these mean and what should be done. So we interpret it for a diagnosis, and so we're always matching the symptom dysregulation. And there's 48 Brahman areas in the brain, and each one of those Brahman areas has unique cytoarchitecture. And then we're going to get to that, how the world of neurology and my world breaks it out into the International 1020 system and how that overlays onto the Brahman areas. But I'll show you a little bit more about that here in a minute. And then the QEG is the other piece of it that I do. It's quantitative. And what that means is you're comparing to normative databases. So like NeuroGuide has a normative database, and so it allows you to compare that brain to brains that are healthy, meaning brains that have never had trauma, head injuries, addiction, or first degree relatives. So which is kind of a rare individual to find somebody like that. And the theory is this, is if that brain is working really well and we're using their networks as a model to, then we're training the other brains to be more in line. Coherence, phase, amplitude, all the metrics of a brain, you're trying to train it. And that's why you're using the z-scores. So it's basically plus or minus 1.96 standard deviations, meaning if a brain goes outside of that and we're using that standard deviation is what we would call normal, we're trying to train the outliers more in line. And the problem with training to normative databases is every person is individual. So when I first started out in this field and I was doing Loretta neurofeedback, and it can be very helpful, but for some individuals, it would just be a slam dunk. I had a client who had been an alcoholic for like 40 years, and he could only train one time a week. And so he would come in on Friday and we'd brain train, and within about 3 months, he was no longer drinking. But he was a slam dunk doing that normative database, training him to match it. But then there'd be other clients when I would see some improvement, but did not see much help beyond that. And so that's when I started to learn about clinical databases, which are part of Paul Swingel's. He started this in the beginning, but basically you're looking at individuals who've come in with symptoms, depression or anxiety or trauma, things like that. And then you're recording the frequencies. And then you use those metrics to compare to other individuals, which is, and so I take all three. I use all the raw, and then I look at the normative database, and then I look at the clinical database. And with all those in mind, along with history of the client and if they're children talking to their parents, it gives me a really good piece of how that individual functions and sees life. Okay, so let's see here. Okay, so I love the EEG, and so I'm about to get to show you my map. And so I kind of wrote this up here because I think it's pretty cool. But that EEG is not just about seizures or sleep, but also cognition, language, attention, and meaning making. And part of the thing I was sharing with Dr. Bruno earlier is when I see a client, so I'll show you some like a Tourette's patient or someone who's has head injuries or depressed or things like that. I'm not just looking for uh, I'm looking for them to improve in that specific area. Like if it's a Tourette's, I want them to improve in their tics. But what I'm also doing is I'm stabilizing the rest of the brain. So not only will I help that part of their quality of life, but then I'll get to help with their sleep, and what plays a factor, but play their sleep and their social skills and their ability to communicate, especially with people with Tourette's. It's oftentimes someone with ADHD, but it's every Tourette's client that I've had is on the spectrum. So it's not uncommon in the autism spectrum disorder. And I like this quote, and these voltage fluctuations are hidden the mysteries of the workings of the human mind. So I'm going to show you I'm going to have to watch the time. How far are we in? Okay. All right. Okay. So this is a picture of my room in 2010 before I started brain training. And I, like I said, I taught a group in a lot of depression and abuse. And so I spent most of my life not liking myself, hating myself, wanting to die. And then once I started going to the psychiatric world, um, when I was in graduate school, I spent 20 years going from psychiatric med to psychiatric med, to therapist, and not really seeing much relief. And then this picture was taken right after I was in grad school to study counseling, and I tried to kill myself again for the worst time. And so I went and told my professor and said I'm diagnosed with bipolar. It's not working. I've been doing everything, and so he told me about brain training, and then here we are. So at the time, I was on Zoloft, lorazepam, alprazolam. It's not 5 milligrams, this one. Lithium and Synthroid, because they had been diagnosed with bipolar after I had another manic episode. I got tickled too because I was looking at my original EEG, and because I went back and worked at the clinic where I was treated, I have access to all this stuff. So he had written in there, patient has long history of psych issues, diagnosed with bipolar disorder, depressed with auditory hallucinations, which I would have auditory and visual hallucination, general anxiety disorder, ADHD. And then I really couldn't find a med that would actually work for me. So, because all the side effects. This was 10-4. So this is the inner workings of that room. So I'm sure Dr. Bruno's familiar with this, but those who aren't familiar with looking at topographic maps that are representation of the EEG, it should not look like this. This is not a sign of a healthy mind. So I don't want to spend too much time on it. So y'all have the slides so you can look at it. So just all my symptoms. But so I'm 60, so it's 2026. And so I reactive attachment disorder. I feel like I'm 90%. This is my first marriage. I've been married 8 years. And so before that, because of all my attachment issues, like I could never marry and have a long-term relationship. But after doing all this brain training, it just continued to help me grow and evolve. Um, and so I don't have asthma anymore. I used to have to wear a bite plate for teeth grinding, so that's gone. So I stopped eating. I lost 60 pounds. Illegal. Like the funny thing is, when I went to share this presentation, I did it at I think it was International Society for Neurofeedback and Research, and it wasn't much longer after it had gotten better. And then before I went up to speak, I was checking the statute of limitations for some of the crimes I'd committed. So I was like, oh my gosh, they're gonna report me. But it's mostly stealing. It's not violent, so don't worry. Hoarding, as you can see, anger, agitation, self-harm, just so much of this kind of represents a difficult life. But anyway, so brain training changed all that. So I'm very grateful. So if you'll get the B-Man's chart, um, it's got all the frequencies on it. This is what it looks like here. I'm just going to give everybody a little bit of time to pull it up. So we want to look at the frequency bands, kind of like gears, right? So delta, but each band isn't just based on a state. It has unique specific functions, which is why we're always kind of playing Goldilocks. We're kind of look at what frequency is dominant and then how is that affecting the way the overall brain works. So we'll just start with that. I'm just going to switch over to the actual slide itself. So this has amplitude, frequency, cycles per second. So identities involved. I mean, delta involved in identity, self-awareness, and sleep. Theta is diffuse focus, emotional awareness, and creativity. But the one thing about theta, most of the time, that's where most tics and seizures live, is in theta, 4 to 8 hertz. So, and I'll share with a Tourette's case later, but when you do an EEG and you do source localization, it just means you're looking at deep parts of the brain and where those EEGs are coming from. And then you can use electrodes, and I'll share with you. I'd use the neurofield system, but you can use these little electrodes and use transcranial alternating current stimulation and transcranial random noise stimulation, and then a certain frequency. Like for Tourette's or tics, you're basically wanting to usually to go on the sensory motor strip, and oftentimes the temporal lobe, and you're flooding it with aperiodic noise or pink noise, and then you're also ramping up 13 to 15 hertz. And you're speeding that up because what you're trying to do is you're trying to teach the brain to hold that pattern. Then alpha, ailing, rejuvenating, peaceful, calm, relaxed, both internal and external focus, except for when you have global alpha, it creates anxiety. Or when you have too much alpha in the prefrontal cortex, it makes it difficult for you to focus. And the interesting thing about alpha, so in the temporal lobes, alpha can be a trauma marker. It can also be a trauma marker at the anterior cingulate gyrus at CZ. And you can also see it at O1. O1 is also another place where you can see trauma, and this is usually historical trauma. But what happens is, like, from a perspective, a survival perspective, the brain's more interested in staying alive than thriving. And so from that perspective, one of the things, and this is a little theoretical, however, the brain will often slow down the temporal lobes to help stop from more emotions coming through. And let's think of this in terms of, if you've got trauma and you've got a event early on in life that you don't remember because it's too difficult, it's too painful, and so the brain wants to kind of like bury it. Well, a way to kind of help bury it is to slow down part of the temporal lobe so less information comes through. So that's one of the things I do when I work with trauma, It's almost like I see trauma as almost like a head injury because it is damage to the brain. And you can see the same thing in CZ as well. And so what we'll do is we'll just ramp up and speed up that part of the brain when you see that alpha. Then we get to beta 1 and beta 2. And most of the time when your eyes are open, it should be in these states. When you start to see beta 3, beta 4, beta 5, we think hypervigilance, we think trauma. The brain's working too hard. It's afraid of the external world. But when we're doing brain training, what we're trying to do is we're trying to teach the brain to have the ability to shift states, right? So you might be working on something and then you really get into it and hyper focus, and so you move to beta 2. But you need to come with a really creative idea so it can hop back into theta, come up with a unique idea, and then hop back into beta 1 and beta 2. So that's what we're trying to do, regulate the brain in such a way that it can control the states that it needs at the time. And then part of what I do when I'm treating somebody who has trauma and they have ADHD, I'll treat the trauma first and I'll try to calm down the system with parasympathetic or tragus. We can catch the vagus nerve, you can catch in the left ear and be able to send signals down it biphasic wave and help calm it down, and helps calm the body, the system. And then the only thing that's not on here is gamma, but that frequency is more about higher functioning, but it also can be a sign of trauma too. If your prefrontal cortex just has tons of gamma way too fast, that's also can be a sign of trauma. It's just being hypervigilant. This is just kind of an overview of the wave elevation, and how to interpret it. It's kind of a little bit of what we talked about. We'll just go ahead and any kind of XX slow wave, which would be a delta or theta or alpha, underactivation and poor focus, low processing speed, and reduced cognitive engagement. I talk about then if the excess fast waves, when you start moving to, and when I say excess, either too much or too fast, anxiety and hypervigilance, over control, and cognitive rigidity, reduced self-awareness because you're kind of stuck in this hypervigilant mode, so you don't really aren't able to go inside. And then this is the other part, interpretation of those frequencies. It always depends on context, whether it's eyes open, eyes closed, task active. So there's one of the frequencies. I don't have that to show you today, but there's one of the assessments that I do. I'll give them mental math to work on, and I'll record it CZ. And so I'm not sure, but theta to beta ratio is one of the markers for ADHD, even though it's not the marker, but it plays a role. So I can actually put an electrode here and have an individual do mental math. And the brain, when it has a problem to solve, it should go into 13 to 15 hertz, which I was showing you before, beta 1. But for people with ADHD and they get overwhelmed, theta shows up. Theta frequency, 48 hertz. So it checks out. Instead of engaging, it checks out because it's boring or it doesn't want to engage. So that's an interesting thing about ADHD. So if you look at a SPECT scan of someone with ADHD and they inject radioisotopes, and they'll have you do something really boring, and then they'll get in there and they'll scan the brain. And the interesting thing, I have one of mine, the blood flow literally goes away from the prefrontal cortex. So when you ask somebody with ADHD to try harder, it's literally impossible. So it's a physiological experience, not just a behavioral one, which is the cool thing about all this kind of stuff is because you can actually also show parents that their kid's not just being lazy. They're really having a hard time focusing. And then if y'all pull out the slide, the combined head map of functions, it's a large, it's this one here. It's the second slide. Yeah, it's there it is right there. The head map of functions. How am I on time, by the way? Yeah, okay. Anyway, this is the really cool thing. I really like this. We'll just go to this. So this is how we do what we do. We can look at the frequencies, and then when we're looking at the EEG, so let's say something like somebody's having a problem with word recognition or short-term memory. So if you look on the left-hand side, scroll all the way down the 1020 site T5. That's the next to last one. So this is what this is involved in, this part of the brain. Logical verbal understanding, word recognition, auditory processing, short-term memory, inner voice, meaning construction. And that's if it's functioning well at that site and has the right frequency, and if it's connecting to the rest of the networks. And that's how we know that part of the brain's working well. The fun part of this, so like an even inner voice. So if somebody really has trauma and self-hatred and negative voices, having a slower frequency or too much of a fast frequency will kind of disturb their ability to do this well. So the fun part, when I get to train someone here and I'm training the rest of their brain, you get to hear them coming in and talk in a more logical way and start to have a better internal voice. There was a client here just today that was talking about that 6 months ago, he was in getting out of rehab, and they did this little exercise where they came around and they were asking everybody what they liked about themselves. And he literally said, "I hate myself. There's nothing I like about myself." So we've been training. He saw me 3 months after that. We've been training, and today he was talking about how much he is aware of what he's capable of, how he loves his creativity and his intelligence. And so it's just pretty exciting when you start training those parts of the brain to see those functions come back online. The other big thing is, so look at FP1. So this is your dorsal lateral prefrontal. It's kind of the cockpit of your brain. And if you look up here at FP1, it's involved in attention, concentration, planning, verbal episodic retrieval, visual working memory, orchestrates network interactions, planning, decision-making, task completion. It's also where your problem solving and mood is, right? So I'll just give you a little example of something you can do without even doing a bunch of brain training. There's a technology that I use sometimes because the system I use has TDCS. It's transcranial direct current stimulation. And actually, I'll do it later. But there's a website called totaltdcs.com that I suggest you look at. But basically, and DARPA, the government, started doing this research, but all you have to do, and so when clients can come in for training, it's a device, and all they have to do is put an anode here at F3. This is the dorsolateral prefrontal, and then put a cathode here in the right part of the brain. And what that does is it's almost like someone who's struggling with depression because the right side of the brain is a little dominant over the left. This was when I was starting to do neurofeedback, and it wasn't my clinic, so somebody couldn't afford neurofeedback. I would just have to do counseling, and I got really tired of having the same conversations about how horrible life was. So we had these TDCS devices, so I would basically put that on them and slow down the right hemisphere, and ramp up this part. And then I would just sit them and let them moan and groan for about 15 to 20 minutes until it started correcting that. And they were in a place where we could start solving problems and having new conversations. So just something really little like that. And so a lot of my clients have them and do them in between sessions while we're trying to get the brain in a healthier place. All right. Let's see here. Okay. All right. I'm gonna have to blow through some of this because it's taking me longer than I thought. So this is another key electrode sites and clinical correlates. It's just another kind of more linear version of the combined head movement functions. And I think what I'm gonna do is I think I'm going to hold on a second here. I'm trying to decide what slides I'm going to do, and then I want to get to the case studies. That's what I'm really interested in talking about. This is about asymmetry. And so let me just talk a little bit about the modality that I use. So in my treatment, in my trying to get better, I had an adopted mom who basically paid for me to go back to graduate school and paid for me to go all around the country. So I've done every brain training technology there is. I've used every one. And so the way I got better initially was neurofeedback, which is an operant conditioning model. I don't know if you know anything about it, but basically the concepts that I'm using for neuromodulation are the same concepts as neurofeedback. And neurofeedback falls under the category of neuromodulation. But when you typically hear the word neuromodulation, most people think TMS. Um, and so what I do is not as strong as TMS. I only go up to 2.5 milliamps, and I use a combination of TDCS, which was the technology I was just talking about, TACS, which is alternating current, and it contributes a lot more to quicker long-term potentiation. And long-term potentiation just means, and just to better understand this, think in terms of the brain as energy allocation. The brain really likes to function efficiently. And so when we start teaching it a better, more efficient way to do something, it starts to hold it because it's like, oh, this is less resources. But if it's been working that way for a long time, it's hard. So, and then if someone has trauma, when you start to get the brain and the body feeling safe, there's a little bit of a battle because it doesn't feel right because they're still wanting to be in a your system will still want to be in a fight or flight state because it wants to keep you safe. So it'll be a little bit of battle, and that's where the therapeutic process comes in with this. But neurofeedback's how I first got better. But the problem with neurofeedback, if you move a lot, or if you jerk, if you have ADHD or tics or anything like that, anytime you move, so everything in the system is electrical. So anytime you twitch or you grind your teeth or you move or you blink, it creates these artifacts in the EEG. So when that happens, you're not training. So let's say you're training for 30 or 40 minutes, you might get only about half of that in training. And that's teaching the brain how to function well. So I had insomnia for about a year and a half from working with a lot of abuse. And so I tried every form of neurofeedback and nothing was working. And then I got to a conference to learn about this new system by Neurofield, and it combines pulse electric magnetic field therapy, and I put it on here, transcranial direct current stimulation, TACS, and then TRNS. And just to kind of let you know, the reason why the system is so powerful is so one of the things it uses is TRNS, which is transcranial random noise stimulation. So in the brain, there's these background aperiodic noise, a white noise and pink noise and brown noise, which you use for sleep. And so I can use pink noise, like I was talking about before with Tourette's, and I can flood the system and sort of push the networks and the neurons to connect. And not only does it connect them and calm them down, this excitation happens as well. It makes it more malleable than to come over with other frequencies and get the brain to really adapt to them. So you can make a lot more faster movement. And then you can do things like use subcortical training. So like do parasympathetic training at the mastoids. And when you do it at the mastoid bone, it helps reverberate through the whole cerebral cortex. It's a pretty cool thing. So it helps you get much faster movement. And then we add the PMF coils, and then also do photobiomodulation sometimes. But that's a little bit about the system I use. But the cool thing about this is with neurofeedback, you can't engage with the client or the patient. With neuromodulation, you can actually have conversations. Or with clients that don't want to talk because they're a teenager and they don't want to be here. I just brain train them and we play games or we watch movies. I don't really care. I just want their brain to get better. And when they start doing that, start feeling better and talking to you, then now we get to move into therapeutic modalities or coaching or whatever it is that they're needing at the time. So it's a really, I don't know of any other way. And I think with neuromodulation and hyperbaric, which I haven't mentioned before, but it's something I use a lot with TBIs and autism and all kinds of things. But between both of those, there's not a lot you can't make quite a bit of movement on. So the other piece of this is, so there's a whole field of called EEG pharmacology. And so oftentimes when clients come in here and we do an EEG, I'm not a doctor, so I can't tell them, but there's all this research on the brain waves that are increased and decreased with certain psychotropics. So when you start to look at that, it's not uncommon that the excess alpha that we're trying to get the brain to produce is being reduced by the medication that they have. So your brain training and fighting um, what the brain naturally needs. And so part of that is I have a neurologist now who will help me then kind of supersede a psychiatrist and help them get on the right medication. So when we're brain training, the medication that they're on isn't fighting them from getting better. So here's kind of a guide. If it's slow wave dominant, um, theta, delta, alpha, a stimulant's just to kind of increase cortical arousal and process speed. If we have high beta or hyperarousal, an anxiolytic, and a GABA modulating agent, I use a lot of supplements, like high-end supplements, like Ayurvedic and things like that cross the blood-brain barrier and help increase GABA without having to use psychotropics. And then frontal asymmetry, depression, and SSRI and SNRIs, and synergy with the neuromodulation. So when they're on medications, if they're on the wrong medication or if they're taking a medication that's kind of working for them, when you start brain training and the brain starts functioning healthier, then they'll start to feel some side effects from the fact that they have too much medication in their system because the brain is now improving and so it doesn't need as much help. How much time do I have here? 15 minutes. All right. I think I just want to share with you case studies, if that's okay. So I actually submitted this to the Trust Association of America TICCon next summer in Nashville, this case, but I was rejected. But I think it's because they think it's made up and they can't believe it. So, oh, okay. Actually, that's another case. Oh, that's the sorry. Oh, hold on. There it is. Okay. Oh, this is the current one here. So, she's 11. She's ADHD, high functioning autism, Tourette syndrome, social anxiety, extreme sensory issues. So this is a client that you couldn't put ice in your mouth, you couldn't drink water, you couldn't cough, you couldn't make any noise with your lips because her sensory issues were so bad. And when you would do something like that, she would just scream. She also had all kinds of tics, verbal tics, facial tics, that just happen constantly. And so lots of anxiety. But I've treated her for about a year. We're 90% rid of the tics. Those are gone. And so I kind of talked a little bit before about data. So there's excess data that we trained, and all of our training involves just ramping up the brain to 13 to 15 hertz. That's a very common protocol for Tourette's or for tics or for seizures. That's a really common. And so she was able to calm down, feel safer. She wasn't able to look you in the eye. She was always looking down. She wouldn't approach you and talk to you. And so now, like, she will talk to anybody. She'll talk to strangers. She'll talk to anybody in the clinic. She'll start conversation. She has more insight about herself. And so oftentimes when you do brain training, not only do you improve the IQ, but you also improve the EQ. But for someone who's on the spectrum and has alexithymia, if you start to ramp up their temporal lobes, they start to have more emotional reciprocity. They start to understand better what other people mean and what they say. With alexithymia, if you're familiar with it, it's basically a struggle to understand your own emotions. And so they may rise up, but they may just show up as anxiety or frustration or irritation, but they don't really know where those emotions are coming from. And so when you start improving the overall function of the temporal lobes and the frontal lobes, they start to have more insight into themselves and then other people. I typically don't work with lower functioning autistics just because it's hard to make movement because you can't really teach them a lot of skills. So he was um, an individual who had Tourette's, and he thought he was a train. So he constantly made train noises, drove his parents crazy. And so we started doing brain training. And by the time we finished, his Tourette's had reduced so much that he was able to go to work. He no longer thought he was a train, which they may not seem like a big deal, but for someone who's been doing that their whole life and constantly making train noises and walking around and just making those noises wherever he went, to go that I'm a man, it was a pretty big shift. And so we were very excited about not only the reduction in tics, that he shifted in his identity, he was able to sleep, he was able to engage with other people, he had less social anxiety. But this one here, she's no longer has sensory issues. You can eat ice around her, you can drink water, you can make noises. Her social anxiety is improved. Um, her self-awareness is improved. That's one of the things, one of the morphologies we look for as a mu. That's at C3, C4 oftentimes. It's oftentimes a marker for ADHD. You see it in ADHD, you see it in the average population, but you mostly see it in ADHD and autism. And so it's an interesting kind of thing is where it's in the motor cortex, but it often can disassociate and help you not understand how to read other people and talk to them. So a lot of times with autism, we'll train, which is what we trained here with her, is C3 and C4 and the tragus. So we calmed down the vagus nerve, and then we treated C3-4 and just ramped it up to 13 to 15 hertz, and she started to have more self-awareness. And so you start to see some of her autistic traits reduce, and just being more engaging. Let's see here. Depression, you've probably heard the term treatment-resistant depression, which I think is a misnomer and it's misunderstood, and I think it's self-created because I've only had one client that I didn't try everything, but only one client that I was able to I did see an improvement, but not what I would have wanted. But this is a client who had serious developmental trauma as a child, physical abuse, and had depression his whole life. He's tried all kinds of treatments, all kinds of meds, and we just finished with 20 sessions with him. And so we did parasympathetic point 04 to 0.14, and then the same thing. He's on the spectrum. So C3, C4, it helps with sleep, it helps with engagement with the world, it helps him to be able to kind of be more inside of himself instead of and can kind of go between internal to external easier. And then he doesn't have one of the two things that causes cognitive decline over time just is a 40 hertz gamma and 10 hertz peak frequency. So if you look at the V light, they have tons of research on this, but I wear this every day. So when I drive to work, I wear the V light because it works on the posterior part of your head because this is where your alpha peak frequency is. So he didn't even have any because he had so much trauma and so much pain there. He wasn't producing his posterior alpha. And so in this particular case, we trained with his eyes closed. So it helped him improve his alpha theta. And the other cool piece of this is that alpha theta training has been around a long time for addiction, for alcohol, but you can use it for trauma. So while we were training this, then I just had him go through some childhood memories and we're able to clear it at the same time because typical counseling or any kind of working with any professional, if you talk about your trauma without changing the physiology, you're re-traumatizing yourself. It may feel cathartic at the time, but I try to get any client I ever work with, I try to get them to not just talk about their trauma flippantly. I wait until we're actually hooked up to a device, and then we can actually change the physiology so it helps your brain start to let go and separate the traumatic memories from the actual memories. So the bodily sensations and the fear and the hypervigilance, you got to see the separation of them. And there's a space between stimulus and response. And so a lot of people that come to see me have severe trauma. So what happens is when we start to improve the brain and calm the system, it increases their ability to experience something, to feel something, and to be able to stop and recognize what it is, breathe, regroup, and then make a decision. And so that's a lot of what I see with trauma is attachment too, is that someone says something and they're looking to see if this is a threat. They don't love me. They don't care about me. And instead of having an attachment response where they just pull away or attack, it opens up that space for them to actually think and behave differently and shift, or even communicate like, this is how I'm feeling. That's one of the cool things that happens with brain training and seeing the efficiency of the cerebral cortex. How much time do I have? Okay. Let's see here. I'll just share a couple of the cases. This was the other Tourette's. This is the one that I submitted to Tourette's Association of America, because the best thing they've got is deep brain stimulation with this surgery, and that only gets about 60% reduction of tics if it works. So I didn't know what I was doing when I started treating her. It was when I first started doing neuromodulation, and so I got some help, Nick and Tiff, and then, but she was coprolalia, inappropriate words, so she would say cuss words, yell them out. I remembered when I first asked her, "May I put an EEG cap on your head?" She's like, "I'll smash your face with a baseball bat." But she would catch herself because she couldn't control it. She'd say, "I'm so sorry. I'm so, this cute girl. I'm so sorry." Then flip me off. "I'm so sorry," but she couldn't control it. Her brothers kind of liked it because they got to cuss at home because she was always cussing. But it isolated her from her classmates. She couldn't date. She couldn't participate in things. And so, after about a year's time, a little over a year, her symptoms dissipated. And so it was kind of cool because I'm big on treating families. And so her dad had PTSD and bad knees from tennis. So I was training him, calming his brain down, and then training her, and we were playing games. And then the other room were her two sons, and we were doing another modality, which is interactive metronome. I don't have the time to talk about that, but it's a neuromodulation technique. And then I was brain training their mom on the other side, who has trauma as well. So the cool thing about training all the family is they started to have better communication, caring for each other. It was just fun to kind of train them all and watch them as a family unit start to change. And then also see her Tourette's go away. And so now she's in college. We're all excited. We were excited to go present that case next summer, but we didn't get chosen. It'll happen. So anyway, this is kind of unheard of. This is a case of autism. This was another high functioning. I may have shared this one, but he just couldn't communicate. He was a brilliant kid, but just couldn't communicate. He couldn't go to school. He was too socially anxious. And so when we finished training, he was able to look you in the eye, talk to you, talk to people in the lobby, talk to the staff. And he went back to school. He's making straight A's. I just got a text from his mom today. And then there was another. I work with a lot of addiction too. This was a special case to me. She had been adopted and had attachment issues, and she had been on fentanyl and meth for about the last 10 years, and she'd get clean and go back, get clean, go back. And so we trained for about a year and a half. She had a lot of head injuries as well. And so we did brain training and then hyperbaric. And so it's 2.5 years later. She's getting married. She's had a job for the last 2 years. She's happy. And so she's more connected to her stepmom and her TBIs. That was a big part of it too. And with TBIs, you usually see them in slow wave activity. And so when you ramp it up to 13 to 15 hertz, the brain starts to heal because it increases blood flow and it speeds up that part of the brain. Let's see here. Okay. Which one is it? Okay. All right, I'll just go through this really quickly. This is kind of my process. I do a thorough interview with clients and parents of their kids to kind of see what the background is. And then I look at the brain wave and identify abnormal frequency increases or decreases. And I showed you the head map. So I'm looking at all the different parts of the brain, what their functions are. So I'm basically matching the EEG to the symptoms. So, and then that's what I'm doing, matching translate findings to neurobehavioral issues. And then I'll always make sure and ask the parents or friends if they're willing to let me, because people that have had long-term mental illness, and about 95% of the clients I see are neurodivergent, ADHD or autistic, primarily because their parents struggle with their own emotions and have a hard time communicating sometimes and being nurturing or loving. Not that they don't try to, but they have struggle with self-regulation. And so they have children who also have ADHD or autism, and then who have also had problems with relationships or attachment. So I'll often talk to the friends or family if they'll let me, because they're better at having insight into what's going on as opposed to the client. Which is why many people come to me who parents are like, or they'll say, I think I'm autistic, but I've been to a lot of places and they said I'm not, because they've used paper metrics as opposed to an EEG and being able to kind of read some of the signs. And then there's a perception of emotion assessment that I also do. And then predict response, estimate medication responsiveness. If they're on some kind of medication, I'll work with a psychiatrist to help determine how to titrate, or if they're willing to change the medication to something that matches EEG pharmacology. My preference is, if they'll play ball, is when we start brain training, we can just use supplements to help maintain them without having to go back on most psychiatric medications. Do you have any questions? I know there was a lot. Sorry if I spoke too fast.
Excellent, Brian. Thank you so much for sharing your own story and your brilliant presentation. Pessoal, eu gostaria de abrir a partir de agora para perguntas, tá? E no final eu gostaria de fazer alguns breves comentários aqui também. Então, a partir de agora, quem quiser postar no chat, estamos abertos aí, Brian, para responder as perguntas e, se é possível, também posso ajudar.
I'll stop sharing my screen.
So while people sending you their questions, Ryan, I would like to ask you something. I'm not sure about how simple is this question, but since we have many students here, what kind of the advice can you give to them regarding, I mean, how to start in this QEEG neuromodulation world from the scratch? I mean, from the beginning.
When I first see a client,
As a doctor, as a student.
oh, if they wanted to learn.
Yeah.
So, BCIA is the licensing agency in America. Well, they also have a European version of it, but it's fairly simple. There's not really a school, but basically you have a 36-hour class that you have to take, and then they have a recommended reading. But if you go to you don't want to do an online class, you want to go to an actual class, because you'll get to practice putting electrodes on, and you'll get to see how that works, and you'll have someone who teaches you and gets to share stories like mine of different treatment modalities, and protocols and things like that. But that's a really good place to start. Because I do neuromodulation, School of Neurotherapy.com is the education branch. That's a great place to start. I've sent Dr. Bruno, some of the stuff I sent you were from them.
Yeah, nice. Thank you. Thank you so much.
Yeah. And then I can share, there's a book that I would start with, there's a couple books. So there's one, and I can send these resources to you if you want, but
Mm-hmm.
functional
Thank you,
neuromarkers,
please. Yeah,
functional
please.
neuromarkers for psychiatry. You may just put them in this chat here,
You can
or just
send me afterwards on WhatsApp. I
yeah, I'll
can
just send them to you
share. Yeah,
later.
yeah.
Yeah, Yuri Kropotov's functional neuromarkers for psychiatry. Uh, the Thompson's functional neuroanatomy was a really
Mm-hmm.
good deep dive.
Excellent.
Those are two that I would start with.
Nice, nice. Another thing, Brian, it's to me is not so clear. I don't know how it's happening in Europe, Asia, but at least as far as my are concerned, here in Brazil and in US is the same. What's the hell the doctors they don't trust in KG neurofeedback, even though they have been doing invasive neuromodulation for the last almost 40 years. Do you have something in mind to explain why doctors they don't believe, they don't trust in this technology in intervention?
Do I have to be politically correct?
No, you don't need it.
No.
Yeah.
Two words, big
Mhm.
pharma.
Yeah.
Um, Doctors are trained
Yeah.
specifically, even neurologists, in how to dismiss medication.
Hmm.
So,
Yeah.
and it's baffling to me
Yeah.
that individuals who come here who are struggling with all kinds of mental health issues and the medications they're on are making it worse. Now, it may
Mhm.
be numbing them, so less emotions are coming through, but it's literally not providing the support that it should be because the brain is the only organ that isn't looked at before it's treated. If you went to a cardiologist, they
Mhm.
wouldn't say, "How does it feel? It hurts." Okay, cool. Here, try this. Um, so it's there's no school that teaches it, but I don't think there's really a big interest in it again because that's why insurance doesn't pay for it. And the other thing about this whole field, it's infuriating. Is it just like anybody else? It's the quality of the person providing those services. So I've been doing this a long time. I had to fix myself. So I've come across all the different treatment modalities, all the different techniques, and I've been using them so a long time. So I found the best. And so I'm confident in my skill set. However, there's lots of individuals that aren't so good at it. And you can go on Facebook and you can see lots of people who've talked about all the side effects, all the things that didn't work out. So besides the fact that big pharma doesn't really want it to happen, they're not really helping in the communication of or the
Yes.
more uh, collective support. So if you look at the neurology world, like I think Wave, that's a great device, but you're never going to find that in the neurofeedback world. The other thing that's kind of not so helpful is Bob Thatcher um, adamantly opposes independent component analysis, which is a way of looking at the EEG. We use it all the time, but he's fought it so much that it kind of has given us a little bit of a black eye as well. And
Mhm.
then, uh, yeah, the other stuff I won't share, but it's basically about the professionalism of our organization and how we train and what we do. It just the bar needs to be raised.
I see. Yeah, it's a good point. Yeah, because to me, it's there's no reason why doctors they don't trust in this technology because we have been using, for example, electroconvulsive therapy over the last 50 years or so.
Right.
DBS, for example, is a neuromodulation as well, even though it's an invasive one. And it just to exemplify and to talk about this point, only now it's been 2 years or so, Medtronic, which is an American company for electrodes and DBS in this DBS world, they approved the use of closed loop electrodes or closed loop systems for many of those students and doctors are here. Those systems, closed loop systems, they can at the same time evaluates the signals like beta wave, for example, and the subthalamic nuclei. And at the same time as they can measure beta waves, they can deliver more power, for example, to the subthalamic nucleus if you have, for example, more if you have increasing beta wave in this area. So
Right.
it's a magnificent technology, but it's not absolutely nothing new because this technology is I would say it's out there. It's been at least 20 years or so, and only now neurosurgeons they are aware of this technology and the way by which we at least should use brain oscillations in order to treat our patients. So to me, definitely, it's kind of hard to understand how doctors don't use this technology so far.
Well, it is. There's like I know Dirk DeRitter uses some of this stuff, and so the other piece of that is that so I used the like this neurofield system. Well, I won't share that part. Anyways,
Okay.
there's things that we can do with frequencies, like frequency medicine, that you can help with the immune system. You can help with the gut. You can do all the things. You can. Uh, I used it with my mom when she had her lymph nodes removed, and so her feet would swell up, and I would put these coils and put inflammation reduction frequencies, and over time, it help align the cells and evacuate the fluid. There's stuff that we can do that just can't be touched with anything else or by anything else. Like I mentioned before, when you start calming down the system, so I don't have asthma anymore, which
Mhm.
is you can't promise that, but I have
Yeah,
lots of clients that have all kinds of reversal of symptoms um, from brain training because you're calming the overall system down, and then the immune system can start to heal itself and heal other parts of the system.
I see. Nice, excellent. Armando Ribeiro is asking if you guys in the West has in the psychology university QEG and neurofeedback as a regular subject discussing.
No, there's only a few. There used to be a neurofeedback lab at University of North Texas. That's been closed, but the only one that I know now in the States is actually University of Texas in San Antonio.
I
They have a
see.
neurofeedback lab, and they'll allow people to go in, but it's as a general rule, it's not adopted across
Mhm.
the country. There are pockets of it, like the Northeast, the Northwest. It's becoming more popular, but the neurofeedback itself is, but the neuromodulation, which I use, is not done by that many people
Mhm.
because it's kind of a new, even though the technology is old, like the TDCS and TACS is old technology, PMF is old, but the way we use it is it's kind of a new way of treating clients.
I see.
And the other thing I was going to tell you too, Dr. Bruno, is there's a lot of proprietary systems. If you've looked at neurofeedback world, there's a lot of different proprietary systems, and they kind of like to kind of keep things to themselves, what they're doing. So that doesn't help either. There's not a unified front on certain technologies.
Got it. Interesting. Hein was asking. She said, I'm a neuropsychologist. I used to support neuropsychological assessments, and I also do neurofeedback with a less complex system. However, the process still follows 5 stages. Brain trainer is the difference. What I feel is missing more content on how to support the diagnosis process, especially regarding the association with brainwave patterns. Can I use this system to establish a diagnosis based on these brainwave patterns? She was asking.
Is she so she does uh so you wonder about diagnosis just from the EEG?
Yeah.
So you're not supposed to diagnose just from the EEG load.
Mm-hmm.
So it has to be a combined, and I don't really do it either. You spend time with the client, you get to know them, you watch their state, their facial expressions, and then I also do a lot of CNS vital signs, which gives me some other information like perception of emotion test.
I see.
So,
I see.
but there's not a
Because, yeah.
software that just the oh, I'll say this. There is actually one. It's called SIBA, and
What is that?
it's a
Mhm.
specifically made to then assess someone for ADHD so then they can give medication. It's the
Mhm.
only one that proved for diagnosing. And so all it tests is at CZ, I think, theta to beta ratio, which is not the only factor. but it's a way to kind of say, okay, this is closer, and then you can give medication. I don't know how popular that is, but that came out several years ago. But as
I
far
see.
as any other, yeah, but as far as just a system that says, here's what this is, and here's the diagnosis, no.
I see. Because there are many, I would say, at least as far as I'm concerned, here in Brazil, many professionals in this field, they start the neurofeedback issue and they don't perform another EEG at the end of the process.
Right.
So my question is, do you think it's a nice approach? Yeah, for example, if a patient get improved his or her symptoms, do you still need to perform EEG afterwards at the end of the process, or you
You
don't
don't have
consider
to.
it?
I've had some clients that haven't,
Hmm.
but it really helps for them to get most people want to see it because they want to see
Yeah.
they're feeling better, but they almost want to see confirmation in the brain.
Hmm.
So most clients want to see that, and it's a really fun thing to compare to, where you're able to see, okay, improve this much percent,
Yeah.
this part of the brain. Um, but it's not necessary. And I've had clients that leave before they come back and do another brain map. But and if we're talking about while we're talking about this, I'll just go ahead and mention. So we're talking about long-term potentiation. You want
Hmm.
to train the brain enough where it's starting to hold that pattern. And so some people will train and they're just tired of it and they'll go and they'll realize they left too soon and come back and train a little bit more. But most of the time when someone leaves me, then they're mostly good. They may come back and have a little touch up and train their brain to remind it that's the way we want to wire. But um, most patterns, if we train long enough, will hold.
Cool. Got it. Thank you. Anyone else would like to comment something, to ask some question to Dr. Bryan, please feel free. Clara, who is a student from our university, she was asking about, could you please share your experience with any of these conditions like chronic pain and or for example AOS using QEEG and neurofeedback?
Pain management is a tricky one,
Hmm.
but there are some pain networks that you can train in the brain, and then sometimes we'll train. I had somebody who had MS, and so sometimes we get rid of their pain for 2 3 hours. Sometimes we get rid of it for 8. But there's no guarantee. It's just kind of
Yeah.
it's because the brain you experience pain in the brain. So if you start to train it, you can actually see some reduction in symptoms, and
Yeah.
it doesn't mean the pain goes away, but it can mean it may not be as abrupt or as
Interesting.
difficult to tolerate.
Yeah. We are performing a study at the university right now, Brian, regarding spinal cord stimulation. And basically, we are studying spinal cord stimulation on and off, comparing those two stages in terms of which kind of activation, brain activation, cortex activation, can you see when the spinal cord stimulation is on compared to off.
Oh,
And
cool.
what I mean by that is because we did a case last year, and basically what we saw is uh, was really fast when you turn off the device because you turn off with Bluetooth, for example. It's pretty simple. Simple. You can see all of a sudden the alpha waves kind of shining in the parietal area from this patient in particular. So there are not so many papers out there proving this point. So that's why we've been trying to study those patients.
And what kind of neuromodulation are you using, or what?
Yeah, it's spinal cord stimulation. We
Okay,
use
spinal cord
for
stimulation.
failed back surgery syndrome and
Okay,
for complex pain syndrome as well. And what else? Herpes virus. Those are the most common conditions that we see. And but it's kind of difficult to understand the pathophysiology of this process. That's why we've been trying to study those patients. Because as I mentioned before, Brian, as a doctor, I should use at least in the beginning those conditions and those patients that I got in my clinic. So that's why we've been studying Parkinson's, uh,
Very
chronic
cool.
pain. Yeah.
Have you heard of PONS?
No, never.
I will send that to you. They found they can stimulate the tongue. They're using it with MS patients and helping their
Mhm.
pain and their
Mm,
gait. It's quite interesting. I will send that to you.
nice. Thank you.
Um,
Okay, Dr. Beatty was asking us, thank you for the informative presentation. In case with both excess slow waves and excess high beta, do you typically prioritize calming the hyperarousal first or increasing activation? And what guides that order of operations?
so um, my basis for that is how hypervigilant a client is. So if
Hmm.
they're in fight or flight all the time, I'm going to slow them down. And one of the fastest way that I do is the vagus nerve. You can catch it in the ear. So I'll use this little clip and do biphasic wave, and then it sends the signal all the way down to calm down the vagus nerve. And the other thing I'll do is over the coils over the head, especially down the midline and temporal lobes, and then the mastoids. I'll use a parasympathetic, which is 0.04 to 0.14 to kind of address the subcortical. Once I start to slow them down, I might do like 5 or 10 sessions of that, and then the resources. That's what I'm talking about energy allocation. Trauma eats up lots of resources. It
Hmm.
really does. And so once I calm their system down, then I have some energy left to then use to then ramp the brain up, because it's much easier to calm somebody down because the brain's saying, ooh, less energy that I have to use. But when you
Hmm.
start to ramp them up, it's like, you're asking me to create something I don't want, which is why it's really much easier to help with a hyperactive ADHD person, to get them in a better
Yes.
place than inattentive, because you're having to ramp that alpha up to a faster frequency, and the system's like, it just takes
Makes
more
sense.
effort.
It
So I
makes
do it in two
sense.
stages: deal with the
Hmm.
trauma, free up some energy, and then they're in a better state, and then you start to ramp up the. Now, sometimes I'll do both. If they're in school and it's really intense, I'll try to like split the difference and calm their symptom their sympathetic tone, and then also ramp up part of their brain so they can focus for work or school. But I prefer to calm everything down first.
Cool. Thank you. Yeah. Anyone else? Carlos, you wanna add some comments?
I really loved the head map of functions. So Brian, I've this is the first time we get to connect. I'm very happy for your collaboration. And it's I've seen a couple of webinars on different conditions out on the field. This is the first time I get such a structured head map of functions, and I really
Yeah.
appreciate someone putting
Yeah.
that together. It's really cool. I really like it, and I think it's very informative. You know, sometimes I get the impression that people out there, not to mention any names or trends, but feel like people get like very hyped about just talking in a very scientific, elaborate way without transmitting any information whatsoever, especially because the field is not so widespread as theoretically we would like it to. And this sort of material makes that very possible, you know. So a huge shout out to you and the work you're doing and for sharing this information. It's very valuable. Thank you.
Well, thank you. I didn't just by the way, probably would have should have shared the source. I didn't do this, and it's also I'm recreating it because it also doesn't have delta,
Yeah, no, I
or
figured that.
gamma, or
I
so.
figured that just the fact of you putting it out, sharing it,
Yeah.
because if it were something that everybody was like very hyped to share, this wouldn't
Right.
be the first time we would be looking at it. Because like I said, I've listened to a couple of webinars, been to a couple of courses out there, a little bit in Europe, a little bit in the US.
Yeah.
So just a shout out to you because you're putting this important information out there. So thank you very much, Brian.
Okay. You're welcome. Nice to meet you.
Nice to meet you too.
Muito bem, pessoal. Agora em português, gostaria de agradecer a participação de todos. É um prazer estar com todos aqui. O Bryan pôde compartilhar a história dele, história incrível, né? E foi muito, muito prático, né? E esse, como o Carlos falou, né? Esse red map aqui, eu acho que foi uma das coisas que, de fato, eu nunca tinha visto isso também. E é muito bom, é didático, né? Você consegue, com olhar, óbvio que está faltando aqui, não tem alfa, né? Mas alfa, gama, mas já é uma coisa que ajuda bastante, né? Principalmente quando você está começando no QIG, isso aqui vai ajudar bastante, né? Então é isso, pessoal. Mais uma vez, muito obrigado. Gostaria de deixar aí o. Nicole, please, would you like to add something? Some comments, some questions, Nicole?
Oh, hi, this is Nicole. I'm very impressed. And then also, I would like to say Dr. Bryan is a share with your personal history. It gives me more encouragement. I work for the eye medicine and my device. Also, I would like to be invited from your team. Each time webinar seminar is there, please call me. I love to join. And thank you very, very much. And also, we have scheduled from last year, some of the teams comes to visit our headquarters. I'm going to very welcome. And definitely, I will solve all the issues this time. This is going to be my personal priority responsibility to work with the Australia. Thank you very much.
Excellent.
Thank you.
Thank you.
Agradecemos bastante. Boa noite, pessoal. Obrigado, Dr. Bryan, por compartilhar sua história. De muito valor para a gente.
Obrigado, pessoal. Boa noite e até a próxima.